Hi, everybody, and welcome. We'll give it a second here for people to sign in. We're very excited to host this month's webinar with Margo Steinlage, all about Medicare and avoiding Medicare mistakes. The way we're going to format this is Margo is going to go ahead and give a presentation, and she will leave time in the last 10-15 minutes for any questions that you have. What you're going to do to ask a question is you're going to click on the Q&A box at the bottom of your screen. You'll type in your question. You can select anonymous if you don't want your name to be shown, or if you don't, your name is going to display, and then Margo will go ahead and address your questions. Margo has done probably 3 or 4 webinars for our clients over the years, and we always get wonderful feedback that people want her to come back, so she is back again, and we're very appreciative. It is important to note that Steinlage Insurance and 4J Wealth Management, we're not affiliated in any way. Just as Margo does with her business, we try to have a broad referral network because obviously obtaining supplemental or Medicare Advantage plans is a very important part of your financial plan, and we want to work with experts where that's all they do. And Margo and her team, that is in fact all they do. So I'm going to go ahead and turn it over to Margo. And she will take us through avoiding Medicare mistakes in retirement. Thanks, Margo.
Awesome. Thanks so much, Josh. I appreciate the introduction. A little bit about myself and our agency here at Steinlage Insurance. We have been doing this for over 50 years as a family business. We're a 3rd-generation family business. And all we focus on is the Medicare space. We offer free advice, and right out of the gate here, one of the first questions I often get from clients is, how is Steinlage paid? How do we offer this unbiased advice? So I have an entire team of brokers here who are all salaried, and they are not incentivized to make a recommendation to a specific product. When you come on board with Steinlage, we collect all of your provider information, your prescription information, and we are able to sit down and look at your entire situation at hand. Are you needing Medicare? Are you working past 65? Is Medicare the right fit for right now based on, your family dynamics? Do you have a younger spouse on a group plan or a child on an ACA plan? So once we get to know you and your circumstance, we are able to make a recommendation. Once Medicare is required and it makes sense to move into Medicare, then our team is looking at all of the different plan products based on your zip code and your dynamic and making a recommendation with the top 5, 6, 10 carriers to help you whittle down and make a plan selection. We could care less if you select AARP United Healthcare, Kaiser, Aetna, Mutual, if you go Advantage, if you go your retiree plan, if you go supplement. However, whatever plan you actually land on will pay my agency a commission. That is how we are able to offer a free service. When you're sitting down with my team, they are fully removed from that commission and transaction. Again, they are salaried, so we offer this fiduciary-like responsibility to our clients and offer this neutral guidance and accurate information in a very noisy Medicare market. So you can lean on us if there's simple questions, if there's complex questions. We are really able to unfold all of those different layers within the Medicare conversation to help you make that wise decision at the very get-go. And I'll hit on this topic over and over throughout the webinar, that your initial decision as you approach Medicare at 65 is very important, because your decision that you make at 65 or shortly thereafter can have long-term consequences. So it's wise to do your education, buyer beware. Arm yourself with Medicare 101 events so that as you near this 65 and Medicare transition, you know exactly what the game plan is, and you're making the wisest decision for now and also long term. Steinlage offers a white glove service to 4J Wealth clients and your friends. Whether it's just this initial consultation, do you have to take Medicare? What are the rules around entering Medicare at 65? And then once you're moving into Medicare, we offer assistance and help our clients enroll in the specific product year after year and provide annual free reviews. We're very proactive with our outreach to clients. And then lastly, we're offering that back end service as well. So if there's any issues that surface, your drug card is misplaced, there's a billing discrepancy. The pharmacy is saying that the drug is not covered, but the drug plan does cover the med on their formulary. A formulary exception request. We are able to offer these back end services as well at no cost to you and avoid those headaches. We are able to work with clients in all 50 states. We actually have clients in all 50 states, which is unique to a brokerage. So if you're in Northern Virginia and you want to move to Maryland, or you want to move down to Florida or travel to California, we are able to provide guidance in all 50 states. We follow you no matter where you decide to move, if it's on a whim or if you're following an adult child. So today we're really going to look at 3 moving parts in the webinar. First, we're going to look at who is eligible for Medicare. What are the rules around signing up at 65? Do you have to take Medicare at 65 or can you delay it? Let's get accurate information around who is eligible and what is required at 65. Then we're going to look at the different moving parts of Medicare. What is Medicare Part A, Part B, Part D? How does your Medigap, Medicare Supplement, and Medicare Advantage plans fall into this equation? What are the pros and cons of Medicare Advantage versus Medicare Supplement? So we're going to define the language and then also dissect the language. And then lastly, we're going to look at upcoming regulation changes. What is this Inflation Reduction Act that was recently passed, and how is it changing Medicare to your benefit for, in some circumstances, for 2025 and thereafter? What changes are coming down the pipeline? How does it affect you? And then also, if you're a high earning individual under Medicare's rules, we'll look at IRMAA, income related monthly adjusted amount, and how this will affect your premium once you do move into Medicare. Again, if you have any questions, feel free to use that chat box, or let's keep it kind of high level questions. If you have very detailed specific questions, please shoot me an email. I will put my email on the very last slide, so you gotta watch the whole webinar to be able to contact me. Or you can always shoot Jeff or Josh over at 4J Wealth an email and ask for my contact information. I'll give the PDF slides over to you, Josh, so you can share those as well.
Thank you.
Okay, so let's jump into the nitty-gritty here. Who is eligible for Medicare? So the general rule here that I like to hit home on is if you are turning 65, the general rule is that you need to sign up for Medicare to avoid any penalties or gaps in your health insurance. All right. So the general rule is you need to sign up in the 3-month before you turn 65 window so that Medicare takes effect on the 1st of your birth month, in a nutshell. If, like with all things, there are exceptions to these rules. If you or a spouse plan to work after age 65, and the employer who is offering you health benefits under that employment is a large employer, that employer who you're working with past 65 or your spouse is working with past 65, if it has 20 or more employees, doesn't matter if it's part-time or full-time employees, as long as there's 20 or more, then Medicare is optional at 65. In other words, you can stay on that large employer group health plan and delay Medicare at 65. Or you can drop the large health plan and move to Medicare at 65. You have a choice that you need to make Medicare is an opt-in program. So if you're working past 65 and you have large employer group health benefit, you have to tell Medicare that, hey, I'm ready to enroll in Medicare. I'm opting into Medicare. If you don't want to take Medicare at 65 because that large employer group health plan is competitive, maybe you have a younger spouse on the plan or younger children on the plan, and you don't want to kick them off into the ACA market or the Obamacare market, you want to keep them covered on the large group health plan, then you're going to delay Medicare at 65. You're going to stay on that large employer group health benefit and avoid any penalties or gaps in your health insurance and Medicare coverage. All right. You do nothing with regards to signing up for Medicare, because when you want to come off that large group health plan, let's say at retirement or when your spouse is nearing retirement, that's when we tell Medicare that, hey, my husband's retiring at 70, I'm 69, now I want to opt into Medicare, and we submit paperwork to show proof of creditable employer-sponsored coverage and avoid any gaps in health insurance and transition seamlessly into Medicare without any gaps in your benefits or penalties. You create a special enrollment period when you opt to come off that large employer group health plan at a later date. Okay, so the exception to signing up for Medicare at 65, it's generally required. You have to sign up for Medicare at 65 unless you have a large employer group health plan at play. Then it's optional.
Hey, Margo, quick question, point of clarification on this. Let's say you're retired, you're on a group plan, you're after 65, and you're going to be retiring in September. When specifically would you complete the Medicare application? And is there a way to indicate when you want the coverage to start?
Yes. So when let's say you're 65, you did nothing. You stayed on your large group health plan. Okay. Now you're 68 and you're 6 months prior to your transition off the group, your retirement date. Okay. I would start this process and planning 6 months out. And then when we submit your Medicare paperwork, we're going to tell Medicare that, hey, I want Medicare Part B to start on June 1st when I am retiring. So you can be very selective to when you want Medicare Part B to start and make that transition off Medicare or off retirement or off group coverage and into Medicare. You can be very selective and tell Medicare the exact day, the first of the month, you want that transition to happen. The tricky part here, and where a lot of people get into trouble, Josh, is when there's an HSA at play with that large employer plan. And, husband and wife or a family is maxing out the HSA. And now at 68, the employee wants to retire and come off the large group health plan. As soon as we start submitting Medicare paperwork to tell Medicare that, hey, June 1st, we're retiring, we're coming off the group and into Medicare, we're going to make that transition happen on June 1st. But Medicare is going to put the Part A free hospital benefit component in place retroactively 6 months from the month we submit paperwork. Okay, so again, I always recommend you come and talk to Steinlage, talk to me, talk to my team about 6 months out from that retirement date. When you start thinking, oh, I'm going to come off my large employer group health plan, I'm 68, I'm ready to retire, we need to have conversations so that we can time the stopping of that HSA contribution based on the 6 month retroactive Part A start date.
That's super helpful, Margo. And just so everyone knows, the HSA it's referred to as a health savings account, and it's a really special type of account where the IRS actually allows you to contribute pre-tax, have the money grow tax deferred, and as long as the distributions are qualified, it comes out tax-free. So it's a triple tax-free type of account. Margo and I live and breathe this stuff, so a lot of times we just use the acronyms, but HSA stands for Health Savings Account, and a lot of our clients do have them. So thank you for that.
Yeah, and if you are somebody who's like, oh, I'm maxing, I do this. In February, I, transfer over close to $9,000 into my HSA every year, and now I'm done. It's taken care of. If you do that and your Medicare Part A is retroactive, you may have to remove some excess contributions. So it's a simple math equation. You can remove the excess contributions if you make a whoopsie and you over contribute into your health savings account, your HSA. So again, when we sit down with you as you approach retirement in this scenario where you're working after 65, we're going to advise on the HSA contributions. How much have you contributed? Let's stop the HSA at the appropriate time or remove excess contributions. And then let's create the timeline to get you into Medicare at the appropriate date, which is retirement date. So it's a little more complicated in the planning when you are working past 65 from our perspective. But for you as the Medicare beneficiary, if you plan to work past 65, you have very competitive large group coverage and there's an HSA, then you're delaying, you're doing nothing. You don't sign up for Part A because it negates your ability to contribute into the HSA. So we really want to time everything accordingly. If you are on a small group benefit, small employer group benefit, fewer than 20 employees, then Medicare is the required primary payer, which means you have to sign up for Part A and Part B as you approach age 65. If you don't, you'll have a gap in your health insurance. The secondary small group benefit will come back and say, hey, we're not legally responsible to be the primary payer. Medicare needs to be the primary payer because we're a small group benefit. So if you're working, you're a solo practitioner, you have ACA, you have a small group health plan benefit for your employees or for yourself, there's fewer than 20 employees, then Medicare is required. You need to sign up for Part A and Part B to avoid a gap in your health insurance. And then the next question is that small group health benefit as a secondary payer, is it competitive for you and your family? Does it make the most sense to keep that or move into Medicare supplement, drug, or advantage? And maybe if we can manipulate income with, Josh's assistance, maybe we can look at ACA coverage for younger children or a younger spouse. And in some circumstances, if we can get savvy with the planning on your income, then we can say, hey, you can get free ACA coverage because we can manipulate the income and get you fully subsidized ACA Obamacare coverage. Again, we're looking at, does that ACA coverage include your doctors? Does it make sense based on your unique circumstances? There's no one size fits all recommendation here.
Hey, Margo, we get so many questions on this, so I apologize for following up on one thing.
No worries.
I think this will be helpful for people. So let's say you have a couple married, both working, both over 65, and they're on, let's say, the husband's plan through his employer. Does the spouse, who let's say in this case is self-employed, have to sign up for Medicare Part A at 65, or because she's under her husband's health insurance, do these rules kind of apply to her as well, where she can wait until he retires, or is
Correct. Yep.
Okay.
Correct. So she can piggyback the spouse who is a secondary policy holder on the larger group plan can follow the same large employer rules. So two 65-year-old spouses on one large employer group health plan under spouse A, that secondary spouse can delay Medicare A or B and wait the large employer sponsored spouse comes off that group health plan. But if they're on two separate policies, she needs to, the spouse who's working for the, small employer needs to move into Medicare because she's not on the large employer group health plan.
Right. Okay. Man, a lot of permutations. So this is helpful.
Yes. Okay. So this is sometimes the first introduction to Steinlage is just navigating this question right here and creating strategy. And again, this comes from the unbiased advice that we get where, hey, we're telling your clients, we're telling you that you don't need Medicare. It actually doesn't make sense to move into Medicare because you can max out that HSA. You can keep your younger spouse, the kids on the plan. Based on all of the circumstances, you don't need us yet. Call us in 3 years when you retire. Then we initiate the next conversation, which is, what is Medicare? But before we jump in there, when you have the HSAs, I'm a big advocate, I know Josh, you are, of maxing these things out, because when you start using them, not only are there tax benefits, but if you are a high earning individual, you can use your HSA funds to offset the IRMAA premiums, the income adjustments, if you are a high earner in Medicare eyes. You can use it for dental costs. You can use it for prescription costs. The HSA accumulated funds that you have can be used for many qualified expenses. The only thing under Medicare that it can't be used for is Medicare supplement premiums. They are not deemed a medically qualified expense under IRS rules. Really bizarre. I'm not sure the policy behind that, but that's the case. So fair game for almost everything else under Medicare, except for the Medigap, also known as Medicare supplement premiums. Okay, so what is Medicare? I'm talking about Part A, Part B, Medicare Supplement, Medigap, Medicare Advantage. How do all of these pieces move and work together in unison? So when you are ready to come off that large group plan, or you're maybe on COBRA aging into Medicare at 65, or you're on Obamacare ACA coverage moving into Medicare at 65, or you have small group coverage and you have to take Medicare at 65. What is Medicare? Medicare consists of two moving parts, Part A, hospital coverage, and Part B, medical coverage. You're going to get a red, white, and blue card that says Part A, hospital, and Part B, medical when you're fully in the Medicare system. Most of us will get the Part A hospital benefit at 0 premium because you or a spouse worked 40 quarters, which is about 10 years worth of work history, and paid your taxes, and you funded the system. Now you get the 0 premium Part A benefit. All of us will have a standard Part B premium of $174 per month. This is the standard rate. It is adjusted by Medicare every year. It goes up or down by $10. But for the most part, we all have this standard rate for Part B medical coverage. If you are a high earning individual, you will see a surcharge on top of this standard Part B premium of $174 per month per person. So if you made above $206,000 in modified AGI or $103,000 as a single tax filer in modified AGI, then you'll see some type of IRMAA, income related monthly adjusted amount. It's typically a surcharge. You'll see this IRMAA surcharge tacked onto your monthly standard Part B premium of $174. I will go over the IRMAA brackets, what IRMAA you can anticipate if you are above the $206,000 benchmark as a joint filing couple or $103,000. So know that Medicare, I often get the comment of like, wait, I thought Medicare was free. No. You will pay, and you'll pay more if you are a high earning individual. So getting in the door is we're comparing large group coverage versus the small group. In helping you create this strategy, we are factoring in what is the cost of Medicare. It may not be the simple $174 per month. If you are a high earning individual, it might be $400 or $500 a month. And we don't want to advise you on inaccurate premiums. So we are very diligent in collecting income information on our intake form because we want to give you the most accurate and precise premium amount so you're making a wise decision here in this planning exercise. So when it's required to move into Medicare, or it makes the most sense to move into Medicare, and we at Steinlage help you enroll in Medicare Part A and Part B, and we time it, and you get your red, white, and blue card, and all you have is your red, white, and blue Medicare card. If you go into the hospital, I always say, if you get hit by the bus, you have a horrendous year. If you go into the hospital 3 or 4 times, or you go and you need an MRI followed by 6 months of PT, what does original Medicare give you? What are the gaps? So if you go into the hospital with just your red, white, and blue card, you can go to any provider that takes Medicare nationwide. You'll have a roughly $1,600 hospital deductible per 60-day occurrence. So if you go in the hospital in February, and then you go in the hospital again for a different, you go in for COVID in February, and then you go in for a hip replacement in June. Okay, you're going to have 2 different $1,600 deductible exposures. If you go in for that MRI visit, you have 6 follow-up doctor visits and then PT for 6 months. You're going to meet that annual Part B medical deductible of $240. And then Medicare is covering roughly 80% of the bill. So aside from the deductibles, Medicare is covering 80%. Your gap here is the 20% coinsurance. There's no cap or ceiling on that 20% exposure. You'll also see here that there's no built-in drug coverage, dental, hearing, vision. So there's a few other gaps in Medicare, and this is where all of the ancillary products come into play to fill these gaps.
I just want to make one point on that. Let's go back a slide. I just did a quick search to try to put this in terms of numbers. The 20% you'd be covered, the typical, this depends on where you are in the US, but the average cost of a hospital stay per day for a general stay is $2,500 to $4,000 per day. And if it's more specialized, like ICU, it's $5,000 to $10,000 per day. So you can see 20% of a very big number, right? It becomes extremely unaffordable quickly. So just to put some numbers around that, that's how important this Medigap coverage is.
Yeah, it is. And again, this initial decision-making of which pathway to fill those gaps in Medicare is really important, because if you say, hey, Margo, hey, Team Steinlage, I'm super healthy, I want to go the cheapest route possible, there can be some underwriting and health questions and pre-existings that come into play. And I'll explain that here. So as we're doing this education, a lot of people will say, oh, I very clearly fall into one camp or one pathway. I want to go supplement, or I know I want to go advantage, which is the whole point of this presentation today, is to help you kind of narrow down the decision based on all these different, noisy factors. Which direction do you want to go? Because then our team can really be specific in making plan recommendations. Once we make this 2 initial decisions, do I need to move into Medicare? And what's the timing of that? And then once I'm in Medicare, which pathway am I going? Medicare supplement and drug with original Medicare, or am I going into a managed care Medicare Advantage pathway? That's the second decision, which pathway to take. And here, once you are holding your red, white, and blue card, your Medicare card, if you're somebody who says, hey, Team Steinlage, hey, Margo, I really want flexible coverage. I don't want any pre-authorization or restriction on my care. I want to go to any doctor nationwide. I want my doctor and I to make the decisions. Then original Medicare with the supplement and the drug plan is likely the pathway you're going to take. The alternative, Medicare Advantage, puts you into an HMO, PPO managed care networked plan where you have some extra hurdle to jump and red tape to go through when or if you need more skilled care or pre-authorization for surgery. There can just be a little more rule following with these Advantage plans that can lead to a frustrating client experience. Not always, but it is the case in some circumstances. So the important takeaway from here, this slide, is no matter which route you choose, the Part B standard premium, the $174 per month, plus your IRMAA, that income surcharge for high earners, is standard regardless of your decision. Okay. Now, let's kind of isolate the conversation to each pathway. If you want that flexible coverage and you want to go to any doctor nationwide that takes Medicare, then this Medicare with a supplement and a drug plan combination is the route to take. With this level of coverage, you have your red, white, and blue card, a Medicare supplement, also known as Medigap card, and a standalone drug card. You may also add a dental and vision policy. Here we can be very strategic and go with carrier X for your supplement, carrier Y for your drug plan for the best and most competitive rates on your specific medicines, and carrier Z for your dental because your dentist is only a network with one carrier. We can really piecemeal and create a optimal plan selection based on all of these different moving parts. We don't just have to go, one carrier vertical here. One carrier for supplement, identical carrier for drug, identical for dental. And I typically don't recommend that because you're not getting the most value in that circumstance. There's no discounts for stacking your supplement and drug plan and dental like you would see in car insurance and homeowners. They don't bundle the packages. When you opt for Medicare with a supplement, you can go to any doctor that takes Medicare. The provider will bill Medicare and then turn around and submit the claim to your supplement carrier of choice, regardless of who that carrier is. You will never ask, do you take United Healthcare? Do you take CareFirst? Do you take Anthem? You don't ask that question with this level of coverage. You simply ask, Medicare is my primary. Do you take Medicare? When you select a Medicare supplement plan, there's different levels of supplement G, supplement N. If you go with a supplement G, which is the best level of coverage, the most comprehensive level of coverage you can get under a Medicare supplement plan, and you get hit by the bus and you have Medicare with a supplement G, as in girl, your only medical out-of-pocket exposure for the year is that Part B medical annual deductible of $240. Medicare and Supplement G will cover 100% of the medical and Medicare approved claims. 97% of providers nationwide take Medicare. Again, Medicare is being billed first by your provider, and then the residual flows to that Supplement G. Once you pay $240 per year in deductible, 100% is taken care of by Medicare and your supplement. They pay the deductible, they pay the 20% coinsurance. You're left with really no headache of dealing with bills coming in. You'll get an annual notice, a summary notice of what Medicare has paid and your supplement has paid. And it says very clearly, this is not a bill. So it's very headache-free coverage. There's no push-pull third-party managing your care. You'll also get built-in foreign care coverage. So if you're traveling abroad and you don't select a short-term health policy to protect you for non-emergency selections, highly recommend you do that. Medicare will not cover you, but your supplement will allow for 80% coverage up to a $50,000 lifetime maximum. That's built into the supplement, and it's an indemnity plan, so it's covering emergency only. If you want just peace of mind for non-emergency coverage, there's short-term health policies that you can add for your week trip to Portugal or 6 months.
And you would recommend doing that, Margo?
Yeah.
Okay.
Because it may not be an emergency. You may have, just a simple need. You have we had a client on a Medicare Advantage plan in Hawaii who had I think it was a kidney stone, and he went into the urgent care, and his Advantage plan gave him a ton of flack because it wasn't a true emergency. Right. And they made him pay out-of-pocket pricing in that circumstance. So it got very frustrating. So for $200, you can add a short-term travel and insurance policy here for
how do you do where do you go to do that? Is that just
email me and I'll send you a quoting link, and you plug in your travel dates and where you're going, and they'll generate 3 different options.
Cool. Okay. Didn't know about that.
And then with the supplement, again, you have the Plan G, which is, I would say most clients go Plan G when they're looking at this level of coverage. Plan N is a little bit lower in comprehensive coverage. You would have the $240 per year deductible, and then $20 copays at the provider, and then $50 ER copays. Again, Medicare's your primary. Everything's flowing through Medicare then to your supplement N carrier on file with Medicare. But the biggest difference between G and N is if you go to a Medicare approved provider, that provider has the option to either be assigned within Medicare or unassigned, non-assigned. And what that means, Josh, and everyone watching, is if you go to a Medicare opt-in provider that is non-assigned, that means the doctor does not agree to bill per Medicare's reimbursement schedule. And by law, they can balance bill you the excess charges, 15%, no more, above what Medicare reimburses. So easiest way to explain this is with an example. You go in for a primary care doctor visit who is a Medicare approved doctor, but they are non-assigned. They don't agree to bill per Medicare's reimbursement schedule. You go in to see that non-assigned Medicare provider. And let's say for a primary care visit, let's say Medicare approves on their schedule $100 of that visit. Then the doctor, non-assigned doctor, can balance bill you 15% of the $100. So $15 is what you're responsible for. Medicare's picking up the $100, the approved amount. So here,
what would you have to ask to know that? Like, because they would just say, "Oh yeah, we accept Medicare," but is it an additional question? Yeah, but are you not?
Yeah. And when we get your doctor list, again, we're asking for all of this information. When we ask for the doctor list, we are looking to make sure that they are opting into Medicare and they're assigned. And sometimes it's tricky because Medicare will show they're not assigned, but the provider decides if they want to balance bill or not, if they're non-assigned. And a lot of times they'll just eat that cost. So I don't want to scare anybody because we have a lot of clients who, for premium's sake, they want to save $300 or $400 in premiums a year. They will go Plan N. And hey, we can avoid this by avoiding non-assigned doctors or just verifying with an extra question. Do you take Medicare? Are you assigned with Medicare?
Thank you.
And then within the drug plan market, there's 30 different drug plans that we're looking at. Which drug plan with a balance of premiums, drugs being covered on the formulary, is it a robust formulary? And then specific negotiated rates on your specific list of medications, which drug plan has the most competitive copays, co-insurance on those, tier 3, tier 4 medicines that you may be taking. So we're looking at premiums, we're looking at copays, we're looking at robust formulary access. And are they good on customer support? Are you on hold with, a specific Part D plan for 2 hours being bounced around, having the most frustrating client experience? We want to avoid that. So we're looking at many factors when we make a recommendation for a drug plan, not just initial, monthly premium. And what I always tell clients here is you are not buying insurance to protect you from your $0 to $5 copay drugs. You are buying insurance to protect you from the cancer treatments, the oral cancer medicines, the tier 3 Eliquis that costs $600 a month. Okay, so we want that robust formulary to protect you because you can get locked out of a drug plan move, or you can't shop your drug plan any month. You can only shop drug coverage during the fall once you're on Medicare. So we want to balance kind of all of these factors when we're shopping the drug coverage. Again, dental and vision would be an additional recommendation. Again, balancing premium with access. Does your provider take the dental plan? Is there a PPO that they can bill out of network? A lot of times we're calling the provider directly to get their preferred insurance. Who do you work with? And then make our recommendations based on your specific dentist. Okay, that's one pathway. This is kind of the Cadillac comprehensive pay up front and premiums, knowing that on the back end, you are covered very well with very limited exposure and push-pull from an insurance carrier. The alternative is, hey, Margo, I'm really healthy. I don't want to pay $200 or $300 a month in premiums for this Cadillac package. I'd rather take on a little more risk and use my HSA funds to offset that risk exposure. I want to go zero premium Medicare Advantage. And this is what you guys see on TV. If you're watching, the local football game or ESPN, you see it on all the channels. I find myself singing the Jardiance A1C commercial left and right. But if you are looking at this pathway, okay, you are signing up for a Medicare Advantage zero premium plan. Remember, you still have to pay that $174 to Medicare, but when you enroll in your HMO or PPO with Humana or Anthem or AARP, now the question is flipped and you say, hey, doctor, hey, hospital, do you take my Humana PPO? Do you take my Kaiser HMO? Do you take my Aetna HMO? Are you in network with United Healthcare? If they are not in network and you have an HMO, you cannot see that provider. If you have a PPO, then that provider has to agree to the specific PPO carrier's reimbursement schedule before you can go see them. So there's a little more hurdle here with a network restriction, but you're paying $0 per month for that coverage. So this trade-off to low premium is restriction, network restrictions. Play the rules of your insurance carrier's network. Play by the rules of the co-pays and the co-insurance, $100 for an ER visit, $300 for a per day hospital stay. So there's negotiated co-pays in the background. There's very rarely a deductible on the plan. You go straight into paying co-pays for if and when you use care. Every service will have some type of co-pay that you are funding, you are paying. Once your service is rendered throughout the year and the co-pays and the co-insurance that you are paying upfront to receive those services, once those co-pays reach anywhere from like $3,000 in this area to $10,000 in this area, then you've hit your plan's specific annual max out of pocket. And now your HMO or your PPO comes in and pays 100% of your remaining medical exposure and expenses for the rest of the year. Once you satisfy that max out of pocket in medical co-pays and co-insurance, your drug cost and your dental cost and your hearing aid cost do not go to that medical max out of pocket. Those are separate ancillary benefits that don't offset your exposure on the medical max out of pocket. The attractiveness to these advantage plans is cheap on the front end, pay if and when you use care. Hey, Margo, I can save $3,000 a year in premium and supplement premiums and go with this zero premium advantage plan 3 times 10 years, that's 30 grand. Josh is helping you reinvest that money. You're making, hopefully 12% on it. Wonderful. That looks very attractive. But the catch here is that, again, you have restrictions on your care. There can be frustrations or headache from the consumer's perspective. But if you never use care, you have friends who are on these plans and they never use care, they pay $0, they love it. They don't know or they don't feel that push-pull that can happen in a skilled nursing facility or in a specific circumstance where you need a surgery, but the insurance carrier is wanting you to do PT for 3 months before they authorize the surgery. Again, a little bit of red tape here. Another red flag to watch out for is that if you choose the Advantage plan because you're healthy and you want to take on a little more risk, and later you become unhealthy, there's a chronic care need, and you're hitting that annual $3,000, $4,000, $5,000, $6,000 max out of pocket every year, you're going to say, hey, Margo, hey, Team Steinlage, the supplement product looks really attractive because I can eliminate this push-pull and I know exactly what my out-of-pocket exposure is going to be every year. I want to drop my Advantage plan in a few years and move over to the supplement. This is where we see the biggest hurdle and restriction, because the Medicare supplement plans can and always will ask you health questions and assess your health risk when you're moving off this Advantage product and trying to move over to the supplement for more comprehensive coverage. And the supplement carriers, all of them, will make you answer a health questionnaire and assess your health risk. And if you are deemed a high health risk, you're on tramadol, you have PT coming up, or you're on 2 or 3 heart medications, blood pressure meds, you're automatically denied access to the supplemental product, and you're left in this Medicare Advantage market. Now, let me take a few steps back. When you are turning 65, or you're delaying Medicare and you're on that large group plan, and now later at 70, you want to come off the employer plan and move into Medicare. These supplement plans have a 6-month, it's called guaranteed issue open enrollment period, where you are automatically enrolled in the supplement without any health questions. They can't look at your pre-existing. They can't ask health questions when you're in a 6-month window around your new to Medicare start date, whether it's at 65 or later when you come off the group health plan. That's really critical to understand, because when you delay Medicare and move off Medicare from the large group plan and into the supplement and drug plan, there's no health questions. When you're turning 65 and you know you need to go Medicare and you opt for this supplement and drug plan pathway, no health questions. But if you're turning 65 or coming off that group health plan and now moving into Medicare, and you say, I want an Advantage plan, that's fine. And 3 years go by in the Advantage plan market, and now you want to go supplement. That's where the health questions and the denials can come into play.
This to me is arguably the most important slide, right? Because if you don't understand and you go with Part C, you can't just move over to a supplemental plan like as you want, right? You're very restricted and probably, right, would be denied, I would guess.
Yeah, I mean, unless you're healthy, we do see some clients move Advantage to supplement, but we're doing the underwriting review. So not we, I'll make recommendations based on the health questions and the answers, but the carrier will make that decision. And it can be obtrusive. I mean, I feel like a lot of clients get their feelings hurt when they're denied. Like, wait, I'm not unhealthy. Somebody's telling me I'm unhealthy. Like, it can be a little jarring, but the Advantage plans are great if you're healthy. But again, you don't want to get stuck. It's this balancing act. And another thing to note is the supplement market in the last 2 years. I feel like for 10 years, I told clients the average premium increase on your supplement product is 3 to 7%. That's average, that's standard across the board with all carriers. Lately, because of this post-COVID rush and push to go get treatment, everybody was hunkered down for a year or two, didn't get their knee replacements. Now there's this rush and demand for health treatment. The supplements have jacked up their premiums to like a 10 to 12, 10 to 13% increase per year. And so this is not the cheap pathway. So we are seeing like the national average of Medicare Advantage enrollees just take off because of this Medicare supplement premium increase trend. So anyone on the fence here may go supplemental at the start, but don't feel obligated to stay in that supplement if it becomes unaffordable for you. You know, we're working with kind of a naturally higher net worth individual with our partnerships with wealth management firms. and advisors, but we see a lot of people say, you know what, I don't want to pay $200 a month for my supplement. I'm not getting the value. I'm going to drop it and go Medicare Advantage. That's a really easy move to make. But my job and our job as advisors in this space is to let you know what the consequence to that decision is. Is it
Yeah.
short-sighted?
I would just add, like, you're healthy at 65, so you go the Medicare Advantage route. Margo said if you're healthy, you can move back. But as we all know, health can change very quickly, especially, you know, when you're over 65. So just because you're healthy when you do this doesn't mean 3-5 years when you want to make that move, you're as healthy as you were. And so it just makes me, I think you have to do this with your eyes wide open here if you're going the Part C route.
Exactly. And like some people will, and another kind of caveat here within the supplement market, if you're in a majority of states, once you set your supplement, remember there's no health questions to enroll in the supplement when you're new to Medicare, whether it's at 65 or you're coming off the group health plan. Okay, that's an easy move into the supplement. But now 3 or 4 years down the road, your supplement has increased every year, and we're looking at alternative supplements for you to see if we can rate shop to a new supplement for better pricing, identical coverage. In most states, you have to pass medical underwriting to shop from AARP United Healthcare to Mutual of Omaha or Mutual to Anthem. You have to answer those health questions to get approved by the new carrier in most states. So again, your initial decision, even within the supplement market, is really critical. You know, what's their market share? How do they rate their policy? Are they attained age, issue aged, or community rated? What's their rate increase history? Which really, again, you got to look at the average across the board, but I would say who's got the larger market share, who's been in the market for the supplement product for many moons, who knows how to play in that space. And our goal is not to set you with the cheapest plan with the small, 0.5% market share that's going to jack up your rates 20% in 3 years. Our goal is to set you in a stable plan. You know, who's the big player here, because we don't want you to get stuck in a low market, cheap plan that's going to increase substantially higher than the average.
Margo, that's a really, really good point. And to piggyback on that, let's say I go with a supplemental plan G in Virginia here for 3 years. I moved to Florida. Now that's my primary residence. Is this where it comes in? If you choose a United Healthcare because of their presence, it's going to convert. But if you go with a smaller carrier, you may have to go through underwriting with a different state, or am I not?
So there's a distinction there. When you're shopping supplements, they follow you wherever you move.
They do follow you. Good.
But you'll in the UHC circumstance, Virginia has super competitive supplement rates. Florida, you're paying about $150 more per month for that exact same product as it follows you down to Florida. You don't have to underwrite when you're moving states on the supplement.
Okay.
If you're in an advantage plan, these are all dictated by your zip code. So if you go from UHC Advantage in Virginia and move down to Florida, you can shop all of the specific Advantage product in Florida based on that new zip code. And you'll have to make a change. Drug plans too, we have to make a change when there's a state move or you're moving out of the service area.
Really important.
And once you're in and you're okay with the premiums, you can stay in for life as long as you're paying the premiums. They can never kick you out regardless of where you move.
Okay.
So a lot of nuances right here on this slide, but the takeaway is your initial decision has consequences. Choose wisely, do your education, work with somebody who's on both sides of the pathway. I can't tell you how many clients come to us after the fact and say, I only heard about Advantage. They didn't even mention this supplement pathway because you were working with a broker who was financially motivated to put you in the Medicare Advantage product, which our agency, again, my team's fully removed from that. Our agency and agents across the board all agents get paid way more by the Medicare and the Medicare Advantage plans than they do the supplement and the drug plans.
Wow.
But working with a high net worth clientele, 80% of our book of clients go with this supplemental product because they want flexibility and they don't want to get caught, and stuck in the Advantage plan market. The premiums that and the commissions that are coming into our agency, whether it's on the Advantage product or the supplement product, are highly regulated. We don't control that. So if you go with plan XYZ under the Advantage, they're paying us the same. If you're going with, one of the 30 different drug plans, they're paying us the same. We really are removed, again, that hand to mouth, got to get your commission. My team does not have that, it makes for a very easy and pleasant experience, in my opinion. That was the whole goal.
Yes, absolutely. And Margo, we have 5 minutes. We have 4 questions. I think some of them you can go through quickly. I know you're not going to get to everything, and I'm to blame.
Going
for
right
that.
here. Okay, give me 2 minutes and then I'll be done and ready for Q&A.
Okay,
so,
cool.
IRMAA, remember that Medicare standard Part B premium of $174 per month. Medicare is when you move into Medicare, every year Medicare is getting updated IRS information based on your prior 2-year tax return. So if you're in Medicare now at 2024, Medicare is looking at your tax return for 2022. In 2025, Medicare will automatically update your IRMAA and income surcharge based on what you filed on your tax return in 2023. So that adjustment to your IRMAA is happening automatically every late fall, early December, and you'll get a notice for what's to come for the upcoming year based on your prior 2-year tax return. What Medicare doesn't know is if you've had a life event that, hey, maybe you and your wife were crushing it at work, making $750,000, you were in this bottom bracket, and moving into Medicare would cost you $600, not the $174. That's $600 per person plus an IRMAA on any drug plan you choose. Getting in the door with Medicare is going to be, $670 per month, plus your supplement, plus your drug plan or Advantage plan. Okay. What Medicare doesn't know is that you're no longer a high earner because of a life event. And the life event, if you stopped working, if a high earning spouse passes away, if you reduced work hours, we can tell Medicare, hey, don't use my prior 2-year tax return because it's stale. I've had a life event. I've retired recently. Therefore, use my anticipated modified AGI to set my 2025 IRMAA premiums that are owed. Reduce or remove my IRMAA because of this life event. And that's where we come in and advise. We bring in Josh and 4J Wealth, and we say, hey, what is an accurate anticipated modified AGI for 2025? So that we can tell Medicare to not use your 2023 tax return information, use the 2025 anticipated modified AGI to set the 2025 IRMAA rate or remove it altogether. So here, the takeaway is that Medicare for most people is $174 to get in the door, and then add your ancillary supplement, drug plan, Advantage plan. But for like 5% of us, which is probably most of you here, you may see a higher IRMAA surcharge tacked onto that 174. And you can see here, if you're a single filer or a joint filer making above $500,000 and $750,000 as a joint, you're going to pay quite a bit if we can't appeal the IRMAA. All right.
Perfect.
Yeah, so I'm going to stop there. The rest is kind of more geared for once you're on Medicare. We will sprinkle this into the consultation on an as-needed basis with clients. Here's my email, like I promised. These are my 2 brothers. They're in Missouri. Again, I have the offices in Virginia. We have a team of about 23 employees right now. We're growing out the wazoo because, as you are aware, there's many people turning 65. And we do these consultations, what you just saw, 20 a day. So do not feel shy, knock on my door, email me, or shoot me a phone call, and we're happy to help.
Awesome.
Okay, I think we had some questions.
Yes, we do. I'm going to go ahead and read them if that's okay. And we may be going a little bit over, but everyone's still here. So obviously there's interest. So so the first question is, do your best to answer it. But, the question is, why is Medicare so expensive? When they're working in the school system, they're paying a lot less.
Okay, I'll real quickly answer that. So your school was subsidizing your actual premium that you owed for tax benefits. So maybe you paid $100 or $50 a pay period for your employer sponsored plan, but your employee or your employer was covering the $700 in the background. Medicare, nobody's sponsoring or subsidizing your Medicare premium. And in my opinion, Medicare is cheap when you look at Obamacare, ACA, full premium, unsubsidized coverage. Medicare for most people, when you're coming off a group health plan, is substantially cheaper, even with the IRMAA, if you're in one of the lower IRMAA brackets. So the subsidy in the background with your large employer, the school district, is why it was so cheap. They made it cheap for you. They were eating the true cost of the premium.
Perfect. And I think you should be able to answer these pretty quickly. A lot of clients retire military, they have TRICARE, VA Health. How does that overlay with Medicare and what your team kind of covers?
I know we always get a few TRICARE and federal retirees. So I do not do that. We don't, that's outside of the scope at Steinlage, but I have a great resource. I'm going to send her information to Josh so he can relay that over to you guys, or you can shoot me an email and I'll share her info. Her name's Tammy Flanagan with Retirement Benefits. She only focuses on the TRICARE and federal employee health benefit space. And unfortunately, because there is no, third party paying her commissions, she has to charge a fee for service, and it's $600 an hour. She is one of the few people that I know working in this TRICARE federal employee health benefit and coordination space. Highly recommend her service. I'll share it after the fact here.
Could you answer though? Isn't TRICARE for life kind of considered?
Oh, yep. Yeah, it's like a plan F or a plan G, the old school plan Fs. When you have TRICARE for life, you're going to move into Medicare, and then TRICARE for life is just like the supplement in the Part D route. It's fantastic.
Yeah, and so that answers this question. And then I'm 65, retired, covered by my spouse's health plan. I applied for Medicare Part A. My spouse will be 65 in December, still working. Is there any benefit for the spouse to apply for Part A before he retires and while he is covered by his health plan?
As long as there's not an HSA at play, then I recommend signing up for Part A, because it can play in the background for those large employer plans as a secondary benefit. And if you have a higher deductible, then all of your hospital stay would flow through the group and over to the secondary Part A hospital benefit. If there is an HSA at play, then don't sign up for A or B. Delay so you can max out the HSA.
Awesome. Well, I know we are over time. This was, as always, phenomenal, conversational, which I think makes it more interesting. Follow up, you're going to send me the slides to get to people, and then Tammy's info, and I'll get it to everyone who attended. Is there anything else, Margo? Obviously, we always send people your way for the consultation. But is there anything else we should know or ways to find you?
I could talk about this all day. So no, I won't go into more detail, but just shoot us an email. Email is my preferred method of contact. It's just more efficient on our end, but we do the phone consultations once we get past that initial email introduction. So thanks for meeting, guys. And thank you, Josh. I really appreciate the time and the collaboration.
Of course. Always great to have you, and we'll have you again soon.
All right. Take care. Enjoy the first week of fall, everybody.
Take care. Bye, Margo.
Bye-bye.